In this video, I will be explaining the fibrinolytic drugs, which are also called the thrombolytic drugs, and topics that will be covered here include the physiological fibrinolysis and then the fibrinolytic drugs, their mechanism of action, their therapeutic uses, adverse effects, and monitoring and toxicity of fibrinolytic therapy. So in the normal physiology, when a pathogenic fibrin clot is formed inside the human body, the plasminogen gets in contact with this clot. So let's say that we have this clot in this picture here formed inside the human body. This is a pathogenic clot, so the body recognizes that and sends the plasminogen to go in contact with the clot. So the clot would be filled with the plasminogen now. Then the plasminogen becomes activated into plasmin. By the help of the tissue plasminogen activators, the TPAs released from the tissues around the clot. So the tissues surrounding the clot here would release the TPAs to go and activate the plasminogen inside the clot, and the plasmin causes the clot to dissolve. Now these endogenous tissue plasminogen activators bind selectively to the fibrin in the formed thrombus and avoid systemic activation of the plasminogen. And this process is slow. It takes several days to weeks until the clot is fully dissolved. Now, in some situations, like in acute myocardial infarction, when the pathogenic clot is blocking a coronary artery inside the heart muscle, in that case, we need a rapid plasminogen activation to dissolve the clot, blocking the coronary arteries and improve the blood flow to save the heart from dying. So the physiological fibrinolysis is useless because it takes long time and we need a rapid action to save the heart. And that is when the fibrinolytic drugs came into use, and the fibrinolytic drugs cause a rapid activation of the plasminogen to form the plasmin, and the clot will be dissolved in few minutes to hours. But these medications activate both of the plasminogen that is bound to the fibrin inside the clot and the circulating plasminogen. And this leads to the solution of both the pathogenic thrombi that are inside the coronary arteries, for example, and this would also lead to the dissolution of the protective hemostatic thrombi. Examples for these protective thrombi are the thrombi blocking the surgical wounds, preventing bleeding. So in case when we give fibrinolytic drugs, even the protective thrombi would get dissolved, leading to high risk of bleeding. Examples for the fibrinolytic drugs include the Streptokinase, the Urokinase, the Alteplase, and the Tenecteplase. So starting with the Streptokinase is a protein that is isolated from the Streptococci bacteria. It works by converting the plasminogen into plasmin indirectly. So it works by binding to the circulating plasminogen to form a complex that converts additional plasminogen into active plasmin. And it has lower efficacy compared to Alteplase. Now the Streptokinase may cause allergy, fever, and hypotension in some people, and the Streptokinase is relatively cheap. That is why it is the most widely used fibrinolytic medication. The second fibrinolytic drug is the Urokinase, and the Urokinase is a protease that is formed normally inside the kidney to prevent clotting inside the kidney tubules. Because the kidney tubules are small and delicate, they can't withstand blood clotting inside them. So the urokinase is a normal protease that is secreted inside these tubules. It is obtained for medical use by a DNA recombination method, and it has less incidence of allergy in comparison to the streptokinase because the urokinase is similar to human proteins, while the streptokinase is derived from bacteria. Now, the urokinase work on both the plasminogen that is bound to the fibrin and the circulating plasminogen too, leading to high risk of bleeding, which is the same risk with the streptokinase. Now let's talk about the Alteplase and the Tenecteplase. So those are similar to the human tissue plasminogen activators. They are obtained by recombinant DNA technology, and the Alteplase and the Tenecteplase have low affinity for circulating plasminogen in the plasma, but it rapidly activates the plasminogen bound to the fibrin in a thrombus or a hemostatic plug. Now, the low affinity for circulating plasminogen make these medications have less risk of bleeding compared to the streptokinase and the urokinase. But still, since they also bind to the hemostatic thrombi, means they also have a significant risk of bleeding. Now, the Alteplase have a short half-life of 30 minutes. That is why a portion of the dose is injected as bolus, then the rest is given by continuous infusion, while the Tenecteplase have a long half-life. This permits administration as a bolus intravenous injection rather than by continuous infusion. Moving on to talk about the therapeutic uses of the fibrinolytic medications. So they are used in the treatment of acute myocardial infarction, ischemic stroke, massive pulmonary embolism, and arterial thrombosis. And before giving them, check for any contraindications that prevent giving them. So there would be no liability for bleeding. So always check the contraindications before giving them. And they are not used in deep vein thrombosis and most of the pulmonary embolism treatment, except for the massive pulmonary embolism because of the high risk for bleeding. Now, these are the contraindications for these medications. So we have absolute and we have relative, and we have different contraindications in case we are giving them to a patient with stroke. So those are the absolute ones and those are the relative ones. Feel free to pause the video and read them. Now let's talk about the adverse effects of these medications. So the most dangerous side effect of these medications is bleeding, and the risk is higher with streptokinase and urokinase, and the streptokinase may lead to allergy, fever, and hypotension, and the Alteplase may cause angioedema, especially if combined with angiotensin converting enzyme, and the reperfusion arrhythmia is a side effect of all of these medications if used in myocardial infarction. Now, it is very important to know that the patient receiving fibrinolytic therapy should undergo constant neurologic and cardiovascular evaluation and blood pressure monitoring every 15 minutes during treatment, infusion, and after for at least 2 hours. So monitoring is done every 15 minutes during treatment and after for at least 2 hours. Then half-hourly monitoring is done for 6 hours and hourly for 16 hours after injection, and treatment should stop when there is signs of neurologic deterioration or bleeding. So when we have bleeding, we treat the patient with the fresh frozen plasma, or cryoprecipitate can help refurbish the clotting factors, and the anti-fibrinolytic drugs like the amino carboroic acid or the tranexamic acid can be used to reverse the fibrinolytic effect. And with that, we reach the end of this video. Thank you guys for watching. Please give us a like comment your ideas and questions, and subscribe.